So I'm Ari Stromberg, and I grew up in Maryland, in the DC area. I did my medical training, medical school, and my PhD in New York City, medical school at Cornell, and my PhD at Rockefeller University. And then I moved to Chicago for University of Chicago for internal medicine residency, where I stayed on for gastroenterology fellowship. And my research interest is focused primarily on primary sclerosing cholangitis. Next slide, please. And this is an inflammatory disease of the bile ducts within the liver, and it's unknown what causes the disease. And on the left of this slide, you'll see normal bile ducts or healthy bile ducts circled in blue, this is the biliary tree, which is the network of bile ducts that's within the liver that secretes bile, helps digest fats and other foods. But in primary sclerosing cholangitis, it's strictured and it doesn't have the same smooth pattern as you can see, and that's circled in the picture on red, which is a radiographic image of a PSC patient. And the notable, in addition to being a disease primarily of the liver, PSC often co-occurs with inflammatory bowel disease, so ulcerative colitis or Crohn's disease, and it occurs in a significant fraction of patients. Up to 10% of IBD patients will also have PSC. And the curious thing about the PSC IBD overlap is that it seems to be a distinct clinical disease from other forms of ulcerative colitis and Crohn's disease. And this overlap of PSC and IBD has an even higher rate of complications, primarily cancer in both the liver and the intestines, than other forms of IBD. And even though it's this distinct disease with significant inflammation and risk of cancer, there's no specific therapies. We use often the same therapies that we use for other forms of IBD. And there's a significant unmet need for our patients, and we really hope to develop better therapies, which is the focus of my research approach. So the main research question that I'm approaching is whether we can identify personalized biomarkers of disease development, progression, and then ultimately whether we can translate these into therapeutic targets. Next slide, please. And so with the support of GIRF, I'm feel very fortunate to have pursue this ambitious project where we can collect bile acid samples or biliary samples directly from our PSC IBD patients. We're able to collect these with a collaborative teamwork approach with our interventional GI colleagues who perform an endoscopic procedure, a very specialized endoscopic procedure where we can collect samples from the biliary tree. It's called an ERCP. And with this procedure, we collect bile duct samples directly from our PSC patients and compare them to patients who don't have PSC, and we get a very detailed look at the bacteria, the bile acids, and also immune cells that are occurring in the biliary tree, which is the primary site of disease. So we think that this will give us new information and new answers as to what is causing disease or what's driving the disease or what's gone awry and what's promoting inflammation. Next slide. And this integrated approach of combining a detailed look at the bile acids, the microbes, and the immune cells, all in patients from this very select anatomic niche in the biliary tree, which is where the disease is, and it's very hard to access, but we're very fortunate to have the team to actually collect these samples. We hope will give us new insights into what's promoting inflammation, what's driving the development of cancer, and ultimately we hope to translate this into new diagnostic tools and therapies to help meet the gaps in care currently for our patients. Thank you.